Talking about the suicidal attempts and the parasuicidal behavior is again very important. While you're interviewing the patient, you get the idea of the thought content and the thought form of that particular person who is suffering from a behavior of deliberate self-harm. So usually there is a repeated history of deliberate self-harm that is seen in these parasuicidal behavior, in these people who are suffering from this parasuicidal behavior or who are planning to have that suicidal attempt. So basically, when you say, when you regard a self-injury behavior or a deliberate self-harm as a parasuicidal or as a suicidal attempt, it's basically quite a fatal injury, which could have proved to be fatal for that person. And again, the history taking is again very important in that particular person. The risk factors are usually present. He's usually a depressed individual. Stressful life events are usually observed in the past 6 months when you take the history from that person or when you take a collateral history from the friends and the families. So this is basically the management guidelines over here when we talk about them. The suicidal attempts we're talking about in this section. The risk factors will be discussed, and along with that we'll be discussing the clinical presentations that are allocated along with such kind of suicidal attempts. Now, there are a lot of fatal presentations. Obviously, when we talk about the suicidal attempts, they're not fatal all the time. So, but we'll talk about some of the presentations which can prove to be fatal in such a condition of suicidal attempt over here. So the risk factors, as they'll be discussed over here, the rates usually or the epidemiology that is surrounding such kind of a suicidal attempt, that is between 250 to 300 per 100,000 deaths recorded. So this is the epidemiology, and then the commonest reason for the admission is underage, that is 65, and then we have the depressive disorders, we have the adjustment disorders and the personality disorders. So usually the patient would be already dealing with the psychiatric OPD, and he would have a past history of all of these conditions. That is, he would have the depressive episodes in the past, or he had been having the adjustment disorders, especially in the children. If they have basically gone through the parental bereavement, again, there can be the relationship disorders seen in a lot of individuals. Then the personality disorders, so usually the people who are suffering from the obsessive compulsive disorders or the mood affective disorders, they're again basically more prone to this parasuicidal kind of a behavior. So over here, the repeated deliberate self-harm is very important. The history taking reveals this repeated deliberate self-harm behavior. There'll be history to the past attempts or the past attempted suicidal behavior, even in a lot of conditions. The people with a repeated history of DSH are more likely to be diagnosed with the personality disorder, and they're least likely to commit suicide. So again, the DSH is the basically least likely condition to commit suicide, and about 1% in a year, and about 2 to 3% in 5 years they commit suicide. So they're least likely to commit suicide, but still these are the percentages that we have to keep in mind, that they can have the suicidal intentions, or that has to be dug out from the history again. The doctor-patient rapport or the relationship is again very important over here to get to that thought content or the thought form in that particular patient of deliberate self-harm that we have at our hand. And that is basically the underlying management of the patients who are suffering from this kind of a deliberate self-harm behavior. So working as a practicing psychiatrist, you should know how to define suicide. Suicide is basically the act of intentionally causing one's own death. There are a lot of methods, obviously, ranging from the intoxicities to the hanging phenomena, and all of these deliberate self-harm behaviors can end up in the fatality of that person, which is termed as the suicide. So the suicide, previous history of suicidal attempt is again very important whenever we are managing or whenever we are investigating a case of a suicidal behavior. When you have a death at your hand, you have these parameters, that is whether it was a homicide, whether it was a suicide, or whether it was an accidental, or whether it was a natural death. So all of these terminologies should be in your mind. You should know how to differentiate between a suicide, a homicide, a natural death, and an accidental death. So these are the different modes or the different modalities of death that you should keep in your mind. The 75% of suicides, they are related to the men. The age group that is commonly involved for the suicide is the 25 to 44 years age group. The risk factors involved are the age of that person, as we've already said, it's almost the cutoff line is 44 years, and the age and the low socioeconomic class or the cultural background is again very important over here, because that is going to highlight the stresses the person had in his or her life. So the unemployment is one of the major risk factors. It's basically the stressful conditions of life that can range from the unemployment to the relationship difficulties or the bereavement of the parents as well over here. So the stressful life events in the preceding 6 months is very important. It should be marked while you're documenting the history of that person. The relationship difficulties with the spouse is again with the parents, with the siblings is very important, or with the children. Then the drug and the alcohol misuse is one of the leading causes. When you withdraw the alcohol or the drug of the misuse, the patient can go into the withdrawal symptoms, and he may basically get prone to the suicidal attempts. Then we have the psychiatric disorders. The physical abuse history is again very important. That would again highlight the stressful life events in the person's life. So the clinical presentation is usually of the burning skin with the cigarette phenomena. That will again give you the phenomena that the person was in a deliberate self-harm behavior. The superficial lacerations can be present to arms, legs, or the other parts of the body. Picking at the healing scars is again one of the behavior, which is basically indicating the deliberate self-harm behavior of that person. So the fatal presentations, that would basically include the deeper laceration. So when you get that patient at your hand, the type of injuries can range from just the superficial lacerations, or it can range from not giving the healing time to the scars. So all of this is going to point out towards the deliberate self-harm behavior, the thought content, the thought form. The interviewing is again going to reveal the thought form and the thought content of the person, or if he has some plans towards attempting a suicide or not. When he or she basically plans towards committing a suicide, there are a lot of fatal presentations that can end up or that can prove to be fatal for that individual. These lacerations can involve the arterial damage that would eventually lead to the blood loss. The overdosages are also seen in a lot of individuals. The over-counter illicit or prescriptive drugs are seen. Then we can also see the carbon monoxide poisoning, hanging, jumping from the height. So all of these are the different methods that are devised by such individuals. Methods can also range from hanging in 40%, self-poisoning in 25%, and jumping in almost 10% of the individuals. So basically in this section, we highlighted the suicidal attempts and the suicides in general, and what are the causative factors and the risk factors behind it. So that is the end of this section. Thank you for watching sqadia.com.